thank you very much for the invitation. It really gives me pleasure to present to you. I have to give credit to Mary Ann Davies. She's helped me a lot with with the presentation, and Irma Morden at department, and really to be able to draw from such wonderful data to share with you this afternoon. So I'm going to just give you an overall update of COVID-19 in the Western Cape, the emergence of the new variant and how that's affected us. And what about the children? Because that's what you wanted to hear. And the impact of the alcohol ban, which also have some interesting data related to childhood trauma and some conclusions. Just overall, in terms of where we find ourselves in the COVID epidemic in the Western Cape. I actually looked at this earlier. Mignon looks very much like Lion's Head, actually. But it's the first wave and the second wave. And what we do is we've been keeping this dashboard updated weekly ever since the first week in May. And so you've been seeing this unfolding over the last, whatever that is, 40 weeks in terms of that. So right on top, the green line is actually oxygen use. We introduced that, you can see in the first wave as we were going towards peak. And you can see something very interesting about oxygen use all the way along. And this massive peak that we hit in the second wave of going into unknown territory for using up to 80 tons of oxygen per day in the Western Cape, against an average of 12 tons a day pre-COVID. The second line, the blue line, is the total hospitalizations. I'll come back to that, but you can also see the first peak coming down and then a gradual slowing towards the peak and then a deceleration. Then the deaths, the solid red line is the reported deaths. And then the dotted line associated with that is the officially reported deaths. I'll explain the difference between them. There's a slide on the deaths, and I'll come back into that a little bit more. And then the yellow line is the proportion test positive. And you can see in the second wave, we hit as high as at the peak, a test positivity, proportion positive of 50%. So 1 in 2 tests at the peak was positive. And we now, we again now below 20% in terms of, and that's very much Wolfgang's area. But we also, all these markers are now showing a decline. The bars are the actual cases. And you'll see the cases is a Monday to Friday phenomenon. And you'll see the weekends in between all the way as you go. And obviously exacerbated a little bit by the long public holidays over Christmas and New Year. But if you take this dot that I've put here, it's a very interesting phenomenon that we're seeing now, is that probably because of increased admission, that access was constrained at the peak, and that gives the phenomenon of that slightly altered blue line, in that our hospitalizations were severely constrained at the peak. We had days where 10 private hospitals were on divert in Cape Metro at the peak in the first week in January, last week in December, first week in January. If you then look at hospitalizations, so you'll see the solid green line is the public sector, the dotted one is the private sector. ICU is red for private sector. You can see much more private sector capacity. And the yellow line, which is the very constrained public sector ICU capacity that we could bring to bear for both waves. The deaths, as I explained to you. So what we do here is we do the reporting of deaths that we pick up. But then also we do, we in the first wave learned to compete that. So we call it official reported deaths, the total confirmed deaths. And then we started looking at the MRC's excess mortality report. We started comparing with that. And you see then the Home Affairs ones is what we got out of that. So we got all the data that we could get from the MRC and Home Affairs and imported it into our system to get a more complete picture of deaths. So there's a bit erratic in the first wave. You can see the green line and our red lines didn't all speak at the same time. But as we came down the peak and we started going up the second peak, you could see we are very much aligned with the MRC excess report, the green dotted line. And right at the peak, there's some missing deaths. So officially, we have 10,000 deaths. And I'm going to tell you the story of the 10,000 deaths. It took us 8.5 months to get to 5,000 deaths. It took us the last 7 weeks to get to the additional 5,000 deaths. That just tells you how infectious and how high the caseload was in the last 7 weeks in terms of that. The actual total deaths, if you take the ones from Home Affairs into that, is about 11,000. And if you take the total excess deaths with the MRC, it's 13,000. And we're busy reconciling all these numbers to get it as close to zero as possible. The reproduction number is now very strongly below 1. It's now actually 0.5. So obviously for every 2 positive cases, we only get 1 additional positive case. And that's the sharp deceleration we're coming out of the second wave. The overall provincial view, week on week, it's the second week in a row that we have now 49% reduction in cases, 37% drop in admissions, 11% drop in deaths. On the bottom, and this is all on our daily dashboard, so it gets updated daily. Left bottom is the proportion positive. You can see we peaked at 50%. We're now below 20%. The admissions was that strange lag, but it was constrained admissions access at the peak. And now the deaths, which we expect to be a lag, has then also started peaking and coming down. So we close to numbers that we saw on the 13th of December. This is just the metro, a very interesting phenomenon that I'll show you in the metro. But in the metro overall, there's a decline. And southern is where we had the tin roof outbreak in November. Southern is now a rapid decline, about 50% decline week on week in terms, and they're close to where they were on the 1st of December. If you go to rural, Garden Route was first in this province, linked to the Nelson Mandela Bay outbreak and the spread of the new variant. But every other district in rural is now also declining in the Western Cape. We've also implemented something called a wastewater system. So in the city of Cape Town, at all the wastewater plants, there's a measurement of detecting COVID RNA signal in those water. And it's done weekly. And again, we've been tracking this, and it's going to be a surveillance system when we're in the downturn. And it will hopefully be a very sensitive system to tell us there are pockets of outbreaks and go and seek and whatever. What has been very good with this is that we have been able to track our COVID against the wastewater things. And again, with the decline, we can see big declines in the spikes. It is in the metro. It is also in Breda Valley and in Overberg, and we hope to roll it out to other municipalities as well. So the emergence of the N501Y variant 2, I'm sure most of you are familiar with this, but just to give you a sense of this new variant, that's the red bar. When we took samples in October, there were 25 out of a sample, 15, and again, Wolfgang is very much familiar with this stuff, 15 of 20B and 15 of 20A. Those were the 2 prominent variants we had in the first peak. When we got to November, it was completely kind of 111 of the new variant, and the other 2 were squeezed out, which is basically the phenomenon that you see, and that is what Tolo de Riviera was presenting to us on national TV. Same in the metro, in October, virtually 0 of that. And again, it gives you that October was already, it almost landed in Garden Route and then it exploded in Garden Route. In October, there was nothing in Cape Wine, I mean, in some Cape Metro. But when we looked in December out of a sample, 57, and squeezed out the other variants in terms of that. So it really explains that this variant came and then just basically exploded and accelerated the second wave. What Marianne has done is to take our waves and to break the lion's head, that I call it now, into an early wave 1, a late wave 1, between the waves, and a wave 2. So the blue bars all refers to the early wave 1. The orange is for this, it's for the late wave 1. The gray is for the in-between, and the yellow is then for the second wave. What she has found that there's no differences in age, in sex, or comorbidities for the diseased persons in the different waves. So although this then spreads faster, there's no evidence to suggest that it was more virulent, and the proportions are very much the same. So if you look at the age groups, you look at the gender, the one noticeable thing because I touched on that very briefly in the metro, but I didn't show you the active cases. The one noticeable thing is that HIV seemed to have had a smaller proportion because the geographic areas where HIV is more prevalent was hardest hit in the first wave. And we have this phenomenon where we now have evidence, and I'll come back to that, that in Khayelitsha, the second wave is significantly lower than the first wave. And it's a little bit explaining why the HIV then proportionately was lower in the second wave. Then there was the risk of dying if you're in the different waves. So again, the blue, the orange, the gray, and the yellow. And there's really no big difference if you go to each of these waves for each of the groups, the age groups. If you go to 50 to 59, 60 to 69, you'll see it's more or less the same between the first and the second wave. And there was a little bit of a difference that we in the second wave introduced dexamethasone. So when you see that first wave higher, that was in the absence of dexamethasone. Dexamethasone came from the orange onwards in terms of the treatment. And then the risk factors for mortality amongst the cases. And this is work that she's done, analyzing all our deaths. And you can see that the big risk factors is age. So you can see how the risk factor goes up to 16.7 adjusted, the risk factor that you have there, the ratio. If you then go to diabetes, you can see with diabetes, poorly controlled, a bigger risk factor. And you can see with hypertension, the risk factor is not that high as diabetes. And we go to all the others, previous TB, HIV, it's not that high. But the interesting thing, what she then did, is if you look at admissions per week, when admissions per week exceeded more than 600 per week, and that was 500 for the metro only, it starts increasing. And so in the wave periods, in the first wave and in the second wave, the mortality is higher and the risk of death is higher when there's higher admissions. And it comes to this constraining of admitting capacity and having access to oxygen, which is then a factor of another factor for a risk factor for death. So what about children? So all our data that we've got, there's 15,000 COVID-19 cases in children under the age of 20. It's 6% of all our cases. We've also had 1,380 admissions. That's 9% of all PEDS cases. And then we've had 54 deaths, which is a case fatality rate of 3.6 per 1,000 cases. And if we look at the age breakdown, about half of them is in the age group 15 to 19. About a quarter is 10 to 14. And then the rest is between 0 to 4 and 5 to 9. And the distribution is the same for public and private sector testing. If you then see, as the age distribution changed between the waves, and really the proportion of cases that are under the age of 20 has remained pretty constant, except for the southern suburbs cluster. There's a whole lot of 15 to 19-year-old kids that were from grade 9 to grade 10, 11, and 12 that went to the tin roof, and that was a well-published outbreak. And that caused a peak. That was the only peak that you could see in this age group here. But while most PEDS cases are in that 15 to 19, most admissions and deaths were in the 0 to 4 group, in keeping with the patterns for all PEDS medical admissions. No evidence of increased proportion of admissions or deaths in the second wave. And that's tracking to the data that has been analyzed up until January now. And there's a small increase in proportion of PEDS deaths in September, October. And it's likely due to increased testing on all pediatric deaths. And some may be incidental diagnosis. So that's the pattern. So you can see the influence of the southern suburb cluster, the admissions, and then the deaths. Then the risk of admission or death for children has not changed in the wave 1 to wave 2. So you can see the risk of admission is pretty similar for the two. And it's very same as adult analysis, comparing the first and early first wave and the second wave, adjusted for sex, age, comorbidities, and admission pressure. So then antibodies in children is quite an interesting phenomenon. And I'll come back to the point of the protection in Khayelitsha. So as part of the routine surveillance, There's also antibody testing in several sentinel patient groups that we do with our colleagues in HLS, and Wolfgang is very much part of this. And we're using residual blood samples like pregnant women, people with HIV, and to then assess the proportion of children who's been infected with COVID. We looked at the residual sera for 879 children, 879 children aged between 3 and 15, attending hospital for non-COVID reasons. So it's either inpatient or hospital OPD, a mix of surgical, medical, etc. So the overall seroprevalence in those, let's call it incidental, it's antibodies on children that came to hospital for completely different, other than COVID. The seroprevalence in the children were 26%, and it increased during December, the second wave. And the lower, this is lower than in adults. In adults, we found about 30 to 46% antibodies. But the adult samples might also be biased to poorer, younger adults and not represent all adults. So you can see also in Grootske it was 34%, in Red Cross it was 24%, Tygerberg 26%, and you can see the difference over the weeks in terms of that. So the point I was going to make here is that actually what has happened is we also did this with the antenatal samples, and we did it also in diabetes patients for adults. And what we found is, in a sense, what potentially could be the reason why Khayelitsha was relatively protected in the second wave, in that in the diabetic patients, we found that there was a significant difference in the seroprevalence in Khayelitsha as opposed to the other areas. And that what we made assumptions from the antenatal survey was disproportionately representative of the communities where they came from. So we all expected out of that antenatal survey that there's not going to be that big second wave. But actually in Khayelitsha, we fought about 40% in the antenatal survey, but when you did the diabetes test, it was 50%. If you then took, say, Southern, and it was still about 25%, but when we look at the diabetes, it was like something like 10, 15%. So it actually showed that all the other areas were much more vulnerable than we thought they were, other than Khayelitsha, which actually had much more infection in the first wave than the others. So as the alcohol regulations affected children, and this is a trauma against children, you can see the moving average, and you can also see the number of trauma patients at our sentinel sites, emergency centers. So you can also see as the lockdown came in, it reduced. And you can then see the five-week period during the most recent alcohol ban, that's July to August. And then when the ban was lifted from the 19th of August to September, you can see a 25% increase in trauma and violence against children. Directly, you can correlate to the levels of alcohol. Now, obviously, we see a much more dramatic increase for adult trauma and also for gender-based violence. But the correlation, which is a sad correlation, is also directly violence against children, related specifically to alcohol. So in conclusion, there are clear signs from multiple data sources that we've passed the peak of the second wave in the Western Cape. There's easing of pressures. Our local teams remain on high alert for surveillance, and they respond to localized clusters, especially the vulnerable people. Children comprise about 6% of all our COVID cases, 4 to 5% of admissions with COVID-19, and 1%, less than 1% of COVID deaths. These proportions have remained constant over time. The variant, the new variant, version 2, emerged in the Western Cape in October, November, and the initial analysis showed no increased disease severity in adults or children, but the analysis are ongoing. And the alcohol ban has obviously resulted in substantial reductions in childhood trauma present at our facilities. Thank you very much.
That was great, Keith. Really, really enjoyed that. I have asked people to type in any questions that they may have. I think your information is vast. One of the questions are, these are mainly predominantly Western Cape for children. Do we know how the other provinces fared in comparison?
The very simple answer, Minyo, I don't know, because we don't have a comparable database. Yeah.
So very interesting to see that the death rate is still very, very low. And I think that's what people are very, very interested in. So I've just come off a ministerial advisory committee call to come and join this. where we're busy discussing whether schools should say open or close and when they should be opening. And I think our push at the moment is to try and get everybody back to school at the latest the middle of February, just based on the fact that a lot of the infections were actually during the school holidays. And so possibly it's a safer place for kids to be at school. And we're going to hear more about that from Despina a little bit later. So what are the risk factors for death in children? Comes from one of our questions.
Yeah, I think the analysis, and Minyo, you've seen it, and you've joined in DigiCon for me. You could probably answer it better than me because you saw the analysis and it's still very much the same. And I mean, I think quite a lot of rare conditions, but predisposing conditions of immunity. But maybe you can answer better than me in terms of that.
I think last year we had 4 children, and those at Red Cross, and those were mainly children who'd had pre-existing conditions. Some of them were actually on a palliative care pathway. So those children all had really complicated issues, malignancies or cardiac issues. We're still a bit anxious about the new wave to see what's going to happen with those, but that's pretty much what we're seeing at the moment, still in the Cape. It may be different in other parts of the country, but it's still open early days. How does this data help predict the areas that may be more affected in the 3rd wave?
Yeah, so it's very interesting. I mean, none of us, I mean, I was in shock when I heard. We tried to make sense of the 2nd wave and why it was not going to our prediction. So none of us could have predicted because we were thinking we were dealing with the same variants of the 1st wave. So none of us could have predicted this new variant with the 3 mutations and the rapid spread. That was, sorry about that. That was associated with the rapid spread. So what this data does help us with now is we've got this database built up. We will go to Wolfgang and his colleagues and say, can we do seroprevalence again? We now have more insight in the seroprevalence because although this was much more higher spread in a place like Khayelitsha, where the, sorry about that, where the infection was much more severe in the 1st wave, there is obviously higher seroprevalence and higher inherent almost herd immunity in Khayelitsha. So even though this was higher everywhere else, Khayelitsha is actually quite an interesting case study to say, and now the question is, what is then the seroprevalence after the 2nd wave? To say, what is your risk in the 3rd wave? So obviously they will put all of that together. We also now know that there's new therapeutics and there's other therapeutics on the range. We look at all of those things together. And then you would have, I don't know if you've seen it, but Karim spoke today. And he suggested that probably it's more likely that we will have a 3rd wave in about June, July. And it will follow the same pattern. It looks like it will be exactly the same as the 1st wave we had this year. And then we'll have another one in summer. And obviously now the vaccines coming in and how quickly the vaccine uptake is will be another factor. So our infectious diseases epidemiologists will use all of this, put it all together, and then give us some sense of what the 3rd wave is going to look like. But yeah, that's the shortest answer I can give to that question. Yeah.
Looking into your crystal ball, yeah?
Yeah.
There are a couple of questions about school that I'm going to leave Despina to pick up a bit later. And then cases that did not meet testing criteria but could be possible positive cases. I'm going to leave that for Wolfgang, if that's okay. And then the last 2 questions, it's good that the data appears to show that the new variant is not more deadly, but it is worrying that the higher transmissibility rates translates into hospitals under more pressure, resulting in more deaths. And I think that's pretty much what you showed in your
presentation. That's exactly.
Is there any way of monitoring whether the seroprevalence is preserved in the same community over time in Khayelitsha? I don't know if you want to answer that.
Yeah, I think the point is that firstly, their 1st wave was in June, July. You could see that. The 2nd wave was in December. That's 6 months later. There was a variant, and yet we had seroprevalence protection. So there's still, the jury is out on how long immunity lasts. So nobody really knows. But we will obviously see what the seroprevalence is now post the 2nd wave. And then we'll make assumptions about what that will look like going forward. Then there was another question. Yeah, so yeah, that's the question. I think the comment from Catherine is spot on, because that is exactly what we experience. The rapidity, it's how rapid it is. I mean, we shared a statistic today, and I think I shared it with you now, that it took us 8.5 months to get to 5,000 deaths. It took us 7 weeks to get to the second 5,000 deaths. It is just the scale of how rapidly it spread. It's not more infectious. It's not more. It's more infectious, but it's not necessarily more pathogenic in terms of that. But it's just the sheer number of cases coming at the healthcare system overwhelms the healthcare system. And that's exactly where we were in December. The healthcare system was overwhelmed, public and private together.
And that's a question also, could lack of capacity have led to more deaths in the second wave?
And that our data proves that. Yeah.
And then the question about MIS-C, which is the new name for PIMS, which is the multi-inflammatory syndrome. We haven't seen an increased number yet, but in the first wave, we saw a lot sort of 4 weeks to 6 weeks later. So watch this space. Keith, I'm going to say thank you very much. That was really interesting. And for those people who have got people, I've got people texting me continuously saying we're oversubscribed because we're over 300. We are recording this. So I just want to say thank you very much for giving up your time. And I'm going to hand over to Andrew Redfern to introduce our next speaker. Thank you very much.
Thank you very much.
Great to have you.